So today we're going to review the NCCN guidance and evidence for treatment of castrate-resistant prostate cancer. Go ahead and thank you. So our learning objectives, we will outline novel therapies for castrate-resistant prostate cancer that has received approval in recent years, and we will assess available treatment options that are appropriate to the different settings based on symptoms, overall health, and risk-benefit ratios for our patients. To start, we'd like to bring up this first case. This is a 70-year-old white male who was diagnosed with prostate cancer in 2004. At the time, he had intermediate risk disease, high intermediate risk with a clinical T2B exam, Gleason score of 7, high volume of cores, and a PSA of 15. His metastatic workup was negative, and he underwent combined external beam and brachytherapy. From 2005 to 2006, he was treated with GnRH agonist monotherapy as well. And on this adjuvant protocol, his PSA decreased to undetectable levels. However, coming off of the LHRH agonist, his testosterone recovered, and then 6 years later, his PSA began to rise to greater than 2, which is the radiation oncology definition of failure. Restaging scans at that time were normal. He had no evidence of local disease, bony disease, and he was initiated on combination bicalutamide as well as remaining on the leuprolide. And his PSA dropped again to undetectable levels. And then in late 2012, early 2013, his PSA again began to rise on the bicalutamide, and this time had a rapid doubling time of about 3 months. So let's look at the NCCN guidelines for non-metastatic castrate-resistant prostate cancer. First, note that it is essential to maintain castrate levels of testosterone with ongoing ADT. Unfortunately, there is no level 1 data noting a survival benefit for patients who are non-metastatic but have rising PSA on hormone therapy, and the preferred approach is a clinical trial. Observation is favored, particularly for patients who have low PSA doubling time. And as we saw with this case, either the addition of an anti-androgen or withdrawal of an anti-androgen has been suggested. But there is some research on the role of enzalutamide in this setting, but it's unclear whether early use of enzalutamide is advantageous, so it's not currently recommended by the NCCN. Ongoing phase 3 trials will provide insight into how to treat in this setting. Addition of an anti-androgen frequently does have a PSA response, as we saw with this patient, although the median duration of the response is only 3 to 6 months. STRIVE, which compared enzalutamide to bicalutamide, included some patients who were non-metastatic. And we have a little more information for you here.
So great, I'll take over for this data. So we presented this data at the AUA conference a year ago, and then this trial called STRIVE was just published in JCO in February. And so this is new data. It's not reflected in the NCCN guidelines. It's enzalutamide versus bicalutamide in M1 and M0 patients. It was a randomized controlled study, and this is really one of the first studies to look at enzalutamide in these M0 patients, as well as one of the first trials where an active control was used against enzalutamide. If you remember, the AFFIRM trial and PREVAIL trial, which led to the approval of enzalutamide, were against placebo. So these were men who had not progressed on bicalutamide, and they were randomized to either the standard of care, bicalutamide, or enzalutamide. As you can see, the primary endpoint here, which was progression-free survival, and this incorporated PSA into the definition, was improved with enzalutamide about 19.4 months as the median versus 5.7 months with bicalutamide. So bicalutamide does have activity, but the activity tends to be more modest in terms of disease control. Although 5.5 months is decent, enzalutamide provided a greater benefit of durable disease control. And this was reflected not only in PSA, but radiographic progression. You can see the hazard ratio here as well was substantially improved. What is not known is, does the early use of this drug, which is potent and able to delay progression, does that lead to any improvements in survival? Because as you know, many of the patients treated with bicalutamide would then be able to get enzalutamide, and we don't know if the early use of this drug would lead to a improved benefit versus the sequential use of bicalutamide followed by enzalutamide. And thus, just to go back to the current guidelines, you can see that enzalutamide is not listed specifically here. It really leaves the physician to make a decision about what the appropriate risk and benefit would be of either bicalutamide or enzalutamide or nilutamide, some of the other anti-androgens here. If you want to look at specifically in this trial in the M0 subset, most of the men were M1, and overall you can see a magnitude benefit of nearly 70–80% relative improvement in median progression-free survival. PSA response is 81% versus 31% for bicalutamide. In the M0 patients, you see a little bit greater benefit in terms of PSA declines. Over 90% of patients had a more than 50% drop versus 42% with bicalutamide, and 76% had more than a 90% decline. The medians really haven't been reached in the enzalutamide group here, while the kind of median is really around 8 months or so with bicalutamide. So again, we don't have any level 1 evidence that there's a survival benefit to the early use, but this is the first evidence that we have comparing anti-androgens in this M0 patient population. So in general, my practice has been actually to use bicalutamide first, largely because of the cost of the bicalutamide relative to the enzalutamide, that many patients do benefit from the bicalutamide, and that enzalutamide has proven activity and survival benefit after bicalutamide. It wouldn't be wrong to use enzalutamide, but again, we don't have level 1 evidence that men would live longer in that setting. So to take this case further, let's say he was taken off of his bicalutamide. His PSA continued to rise despite a low testosterone, now up to 11.2, indicating no withdrawal response. Withdrawal responses are seen in men with mutations in their androgen receptor ligand binding domain, but many patients will not experience that withdrawal response, indicating some other mechanism of resistance. And this patient's PSA continued to rise. You can see on his bone scan he had widespread osteoblastic metastases. On CT, he really had nonspecific nodules and some small lymph nodes. He remained asymptomatic. And so let's look at the NCCN guidelines for M1 CRPC. And so if you have a patient who is progressing to metastatic CRPC, again, emphasis is to maintain castrate levels of serum testosterone with either the GnRH agonist or antagonist or orchiectomy, to consider adjunctive bone anti-resorptive therapies. I'll cover that subsequently. To consider immunotherapy in special cases of men who are asymptomatic or minimally symptomatic without liver metastases, a life expectancy of at least 6 months, and a good performance status, and this would be Sapulous-LT. To consider palliative radiation for bony metastasis, that's considered adjunctive to all these systemic therapies, and to maintain good palliative care and best supportive care. The branch point in the current NCCN guidelines in 2016 is really at visceral metastases, particularly liver metastases, where many of the agents have been specifically studied based on that pattern of spread. We're going to cover this top box initially, which is patients without visceral metastases, like in the case that we've described. In this case, we have many level 1 evidence agents, abiraterone, docetaxel, enzalutamide. They're really just ranked according to alphabetical order without preference, as these drugs have not been compared head-to-head. So let's cover these. So the typical patient who develops lethal prostate cancer will often progress through local therapy, castration therapy. They will have access to immunotherapy, and we use sequential second-line, third-line hormonal agents. And we're going to cover abiraterone and enzalutamide, where we're now using these much more in the pre-chemotherapy or chemo-naive disease space. Most commonly, radium or docetaxel is used at progression on these agents, and radium, docetaxel are approved in specific indications in the castration-resistant setting, and we'll cover this. Cabazitaxel, enzalutamide, abiraterone are also active in the post-chemotherapy setting, as well as radium, which can be used as further salvage. The pattern of spread is one of the more important prognostic factors in addition to pain, PSA levels, alk phos. We have nomograms that can estimate prognosis in these patients really beyond the scope of this discussion, but many of these are well published and based on the clinical trial data sets. This diagram is really just from JCO in the past month, and we did a large meta-analysis of many thousands of men across multiple phase 3 trials looking at the pattern of spread and found that lymph node metastases really alone, these patients had the best prognosis with survival measured really at about 3 years. Patients with bone and lung metastases really clustered really tightly together, with patients with lung metastases having just a slightly inferior survival to patients with the most common form of pattern of spread is bone metastases, while patients with liver metastases were really an outlier in the opposite direction, where a poor survival was noted at around a year. And so this is why the NCCN guidelines really focus on liver metastases as being one of the poor prognostic findings where, for example, Sapulous LT should not be offered. But lung metastases would be an area very similar to bone metastases where Sapulous LT could be considered. So in a patient with bone metastases, one of the first things is to consider bone anti-resorptive therapies. One of the first trials was zoledronic acid, which in a randomized placebo-controlled trial against best supportive care really reduced the overall burden of disease, the number of skeletal-related events, which includes fracture, spinal cord compression, hypercalcemia, need for surgery or radiation, and it reduced the number of events really by half. Pain, really this is not an analgesic event, but it really prevents the onset of pain. So you can see pain is not improved by the use of this, but pain is prevented. So this is really a preventative agent for skeletal-related events. This led to further efforts to refine systemic therapy to prevent these bony events. As you know, many men have this propensity for their cancer to spread to bone and create harms in the bone, whether that's bone marrow failure or fracture. And one of the key mediators of these pathologic events is rank ligand, and this rank ligand interacts between the osteoblasts and the osteoclasts, promotes bone resorption and pathologic fractures. And so denosumab is a rank ligand antagonist. It's a monoclonal antibody. And in randomized trials, you can see that head-to-head against zoledronic acid, there was a modest but statistically significant improvement and delay in the number and incidence of skeletal-related events. And just for comparison, we show you zoledronic acid over placebo. Denosumab has not been compared with placebo. It's only been compared with zoledronic acid. There was about a 3-month further delay. It's important to note that these drugs really don't have a disease-modifying effect. Survival is identical whether you pick one of these drugs, and the time to disease progression is really identical whether you pick one or the other of these drugs. So this has really an effect on bone strength and skeletal events, not on the underlying disease. The risk-benefit profile for these agents very similar, although you see more acute phase reactions with zoledronic acid. The incidence of osteonecrosis of the jaw is very similar and tends to increase with cumulative use, particularly beyond year 2. You can see overall that the number of skeletal-related events is reduced numerically with denosumab. Certainly the administration through a subcutaneous clinic-based form versus the IV form is more convenient. It's also important to note that studies have been done in the castration-sensitive setting. So there's a question there. Can you define castration resistance? So in the previous studies, castration resistance has always been defined as progression despite castrate levels of testosterone, and that means a testosterone under 50 nanograms per deciliter. So the question is, do these bone anti-resorptive therapies benefit the patient in the castrate-sensitive setting? So these are patients with bone metastases. They're responding to hormonal therapy or just starting hormonal therapy. And the first study to look at this was a cooperative group alliance trial called 90202. It was published 2 years ago in JCO. And the bottom line here is that the early use of zoledronic acid as compared with the standard of care use, waiting for castration resistance to occur, did not benefit the patient. There was no difference in survival, no difference in skeletal-related events. And this was actually a bit anticipated because many of these patients do quite well with hormonal therapy alone, that the risk of skeletal-related events is fairly low in these patients, and that waiting for castration resistance to develop remains the standard of care. This was confirmed in a UK study called Stampede, where one of the arms in the hormone-sensitive population was zoledronic acid, and again, no improvements in overall survival, no differences in failure-free survival. So no clear benefit for the addition of zoledronic acid earlier than we standardly give it. And so the NCCN guidelines reflect this, where zoledronic acid is not recommended until the castration-resistant setting. So basically the NCCN guidance for bone anti-resorptive therapies are that both zoledronic acid and denosumab are effective at delaying time to skeletal-related events in men with CRPC. There's no known clinical activity in hormone-sensitive disease, even though the FDA label includes just bone metastatic prostate cancer. We do not recommend that these agents be used given the lack of clinical benefit and the risks of using these for prolonged periods of time, particularly osteonecrosis and cost. So these agents do not improve survival or delay progression-free survival. So I hope that answers the question. The other part of the question was, is there an absolute PSA level that has to be crossed while having low T? And really it's a continuous thing. So, officially you would be CRPC if your PSA went from decimal points and upwards, so it's a sequential rise. The Prostate Cancer Working Group 2 and 3 really would like to see a PSA that goes at least above 2, but for specific context, there may be situations such as small cell dedifferentiation where you can have bulky metastatic disease progression with a low PSA. So really it's not just about the PSA only. Certainly if you have radiographic or pain progression without PSA progression, it's not just defined by PSA. So there has to be some manifestation of the disease worsening, either PSA, clinical progression such as pain, or radiographic progression such as soft tissue disease, lymph node, visceral, or bone progression. And that's really how CRPC is defined. And CRPC is defined based on low testosterone, not whether a patient has had an anti-androgen. So CRPC is often present by the time you get to an anti-androgen unless you've used it up front. So let's talk a little bit about Sipulous LT. This was talked about in the NCCN guidelines as one of the level 1 agents that is commonly used in clinical practice and is FDA approved in this space. So the way that immunotherapy with Sipulous LT works is that an autologous pheresis is performed on a patient, generally through the Red Cross, and the antigen-presenting cells are collected. These are then pulsed with a prostate cancer-specific protein called PAP, or prostatic acid phosphatase. That's conjugated to an immune adjuvant called GM-CSF. This exposes the antigen-presenting cells to a prostate cancer-specific peptide. Those antigen-presenting cells then process it, present the PAP on their surface. Those cells become more activated. Those cells are then reinfused into the patient 3 days later and then repeated at every 2-week intervals for 3 total doses. The purpose of Sipulous LT is really to get at those antigen-presenting cells, but then to have those antigen-presenting cells then go into the body and activate T helper cells and cytotoxic T cells that really carry out the business of the efficacy of this agent. So those T cells proliferate, they attack cancer cells. This has been shown in studies to actually lead to infiltration into the prostate, for example, in neoadjuvant studies. And this is how it's thought to result in efficacy. The randomized trial of Sipulous LT versus sham pheresis did lead to an improvement in overall survival. However, if you look at where these survival curves separate, it's really at around 8 months that you see these curves separate, and thus the NCCN guidelines really don't recommend the use of this form of immunotherapy in patients with a minimal life expectancy. So you really have to be able to live 6 to 12 months to be able to notice an improvement in survival. So take that into consideration as you're considering ideal patients who are asymptomatic or minimally symptomatic who have metastatic CRPC. There's a 4-month absolute benefit at the median in terms of survival, but you can see that the probability of being alive at 1 year, 2 years, and 3 years is increased in the Sapulosel treated patients. It's an absolute benefit of about 23%. There have been some retrospective looks at this phase 3 trial to see who benefits the most from this immunotherapy. And as you might suspect, patients who don't have as great of a disease burden based on the PSA quartiles tend to have a relative greater improvement in survival. So for example, men with a very high PSA, over 134, this was the upper quartile, had a very modest difference, absolute difference of only about 2.5 months, only a 16% relative improvement, versus the opposite end of the spectrum, a 50% improvement in survival, absolute of 13 months. So this isn't just lead time, this is a greater efficacy in earlier disease settings based on PSA. And so in our own experience at Duke, we've looked at ours and published on this that the median at our institution is about 7. And so we obviously hope that that would translate into a greater survival benefit for our patients with the earlier use. And so this tends to be one of the first things. It takes about a month to give that we would entertain giving to patients before you move on to other therapies. So, earlier use is thus preferred. That's why it's put into the algorithm in the earlier setting. There are no benefits in terms of PSA responses, disease control, but the survival benefit is seen. So it's really a long-term therapy. There's very much no short-term benefits. So giving this early when a patient has the luxury of time is recommended. The downside is much like a blood transfusion, but it's it's an autologous product, so it's generally mild. Infusion reactions of fever and chills in a few percent of patients. This can be prevented through Tylenol, Benadryl, and occasionally a Demerol treatment for very much shaking chills. We did notice in the clinical trial a slightly higher risk in the Sapulosel T arm of spinal cord compression and pain, and this could be simply because of a lack of imaging and the lack of a short-term benefit with this therapy, particularly men with higher volume disease. So if I see a patient with widespread spinal metastases, I will get MRI imaging, and this is regardless of what therapy I'm doing. And if they have epidural disease, I would treat that before moving forward with immune therapy. As I mentioned, immune therapy with Sapulosel T does take a while to work, and so you wouldn't want to leave that high-volume spinal disease really untreated during that time, especially if there's near spinal cord compression. This is a rare incidence, but I point this out because it could be clinically important, and I've talked to many providers where they've seen this occur. And this can be prevented through good spinal imaging and treatment. It's ideally used, Sapulosel T, in men with lower volume disease before the numerous other subsequent therapies that I'll get into, but just keep in mind the reason for this is because there is no short-term benefit of this therapy. And so waiting until advanced disease sets in makes it very challenging. And so this is a NCCN Category 1 recommendation, and these are the indications in the NCCN guidelines. So documenting that the patient's not taking opiates for cancer pain, that they have no liver metastases, a good life expectancy, they have castrate levels of testosterone, and they're progressing, indicating CRPC, that would be the indication. So let's take this case forward. The patient did receive Sapulosel T in 2013. He continued on his ADT. He was treated with denosumab. He did reasonably well, but about a year later, he progressed in terms of new bone metastases. These sub-centimeter lung nodules were not actually visceral metastases. They're just incidental lung nodules. His PSA, however, shot up to 114, so really rapid doubling time. He remains asymptomatic. His alk phos is slightly elevated. His LDH is just slightly elevated. And the next steps to think about are, what do you do next? You've given the standard of care. They're progressing. Now they have CRPC that's continued to progress in this asymptomatic state. And so this gets us into second-line hormonal therapy. So I'm going to cover enzalutamide and abiraterone next. Enzalutamide was developed really at UCLA in the Jung and Sawyer's lab as an anti-androgen that binds to the androgen receptor in the ligand binding domain. It blocks dimerization, nuclear translocation. That reduces DNA chromatin binding and the transcriptional activation of the AR program. In cell lines, it seems to have a cytoreductive property, unlike bicalutamide, which can sometimes even stimulate tumor growth through AR mutations, and delays improve survival in these preclinical models. You can see here it reduces AR nuclear transcriptional activity in the presence of androgen. And so the key message for this presentation is from the New England Journal about 2 years ago. This was the second trial. The AFFIRM trial was a post-chemo trial. This was a chemo-naive trial. Over 1,700 men were randomized to enzalutamide or placebo. The primary endpoint was overall survival. Overall survival was updated this past year at ASCO, and it was a median survival benefit of from 31 to 35 months. That's about a 23% improvement in overall survival. Much more dramatic effect on progression-free survival, about an 80% improvement or delay in the time to radiographic progression or death. Same with PSA progression-free survival. PSA responses, whether it's 50 or 90%, you see in the vast majority of patients. Even RECIST soft tissue responses in almost two-thirds of patients. The ability to delay chemotherapy is really important to patients, as this is a fairly well-tolerated hormonal therapy that you just take at home as a pill. You can see quality of life responses. Most of these patients were minimally symptomatic, but so to see a quality of life response is important, but more importantly, a delay in the deterioration in quality of life was seen. So many of the patients treated with placebo did get crossover therapy. That's one of the reasons that we don't see as great of a survival benefit as we do on a progression-free survival benefit, but nonetheless, this was a statistically and clinically significant difference in survival and led to the FDA approval in this chemo-naive population. One of the questions that I often get is enzalutamide active regardless of where the cancer has spread, such as bone or liver? And the answer is yes. This is a publication that just came out a month or two ago. Chris Evans led this paper. Just looking at the PREVAIL trial and the pattern of spread, the blue are patients with non-visceral metastases. This is progression-free survival. Orange are the patients with visceral liver and lung metastases. And you can see that basically you see a wide separation in progression-free survival regardless of the pattern of spread. And on the lower graph is overall survival. Again, blue is non-visceral, orange is visceral. You see a wide separation, not as wide as progression-free survival again, but it's a still clinically meaningful, important separation in overall survival in both groups, so that the visceral patients live about 5 months longer, and that's fairly similar in the non-visceral subset. So this is an AR blocker. It works regardless of the pattern of spread. The downside of enzalutamide, there's just a few main side effects to be aware of. Fatigue is probably the most predominant side effect, all grades 36%. Some are more severe than others. Hot flushes. Hypertension is an interesting one. We don't have a great mechanism for this. It is essentially acting AR inhibitor, but it's also known to have some activity at the GABA receptor, and there could be some mechanism for inducing hypertension through this. You do actually see this grade 3 hypertension in about 7% of patients, and that's a blood pressure of 160 over 100. And so it's important to monitor home blood pressure and to check on this over time. The risk of falls, probably because of fatigue and the peripherally acting or centrally acting components of enzalutamide do promote weakness and falls and fatigue in some men. It was seen in about 12%, and we actually just published that this in the geriatric population, 75 and older, this fall risk was increased. So something, again, to pay attention to. Fortunately, no major cardiac safety issues. The risk of seizure was under 1% across the board, and actually was 0.1%. So in patients who have not had a seizure disorder or were not at high risk for seizure, this is a very safe drug where the risk of seizures is really negligible. The next drug to consider, abiraterone, this is a really cholesterol to androgen synthesis inhibitor. So CYP17 has the hydroxylase and lyase forms. This is what helps convert progestins into androgens. When you block this, you really see a downregulation of androgens and an upregulation of progestins. This should be an up arrow right here where aldosterone levels go up, and that promotes mineralocorticoid excess, and that's largely through this feedback loop of ACTH. To block that, we give it with prednisone. So prednisone is part of the treatment with abiraterone, and prednisone improves the safety profile and efficacy. Many of these progestins are actually weak androgens, and so if you give it with prednisone, you reduce those androgenic ligands, and not only is the safety improved because you can reduce mineralocorticoid excess, but you reduce androgen agonism at the receptor. And so the data for abiraterone acetate with prednisone has shown a survival benefit in the post-chemotherapy setting as well as the pre-chemotherapy setting, very similar to what has been seen with enzalutamide. Again, though, against prednisone, a really doubling of progression-free survival. This was also accompanied by a prevention of pain, performance status deterioration, the need for chemotherapy, very similar to what was described. Unlike enzalutamide, which is given with or without food, abiraterone is important to understand that you take it without food, as taking it with food increases the absorption about 300%. So this has an FDA-approved label in chemo-naive men as well as post-chemotherapy men based on this survival benefit. The abiraterone side effects are mineralocorticoid excess. Despite the prednisone, you still get some, and it's largely grade 1 and 2. You do see some grade 2 and 3 hypokalemia, fluid retention, edema, some cardiac disorders, pretty modest risk. But hypertension, again, is an important thing to follow and have patients do home blood pressure monitoring, 5% risk with grade 3 or higher. You do see some liver injury in less than 10% of patients, so it's important to do liver monitoring, and I'll get into how I manage patients in just a second. So overall, abiraterone has never been compared with enzalutamide, but looking across these now 4 studies, particularly in chemo-naive men, PREVAIL against Cougar 302, these are the 2 phase 3 trials. This is a cross-trial comparison of the data that I've presented. So abiraterone does require prednisone. It can cause mineralocorticoid excess. Enzalutamide does not have that downside. Abiraterone, the 302 trial, did not evaluate visceral metastases. It has been evaluated and has shown success in visceral disease post-chemo, while enzalutamide, as I showed you, had activity pre- and post-chemo. Very similar side effects, including fatigue, hot flushes, hypertension, some unique liver issues with abiraterone, as well as low potassium, and fatigue and seizure risk for enzalutamide. The grade 3 to 4 adverse event risk is rarely identical. You do see slightly greater on-target effects for PSA reductions, soft tissue reductions. So if you have a patient really in need of a strong response, enzalutamide has a numerically higher radiographic response rate. But the progression-free survival, overall survival, looks fairly identical across these trials. And again, we don't have any direct comparisons. So the timing that I consider, this is in the NCCN guidelines, there's no specific preference for one of these agents because they haven't been compared. And the choice is largely not based on efficacy. It's because I showed you very similar survival, progression-free survival, that we largely make the choice based on patient-specific factors, differential expected toxicity. So abiraterone would be a more appropriate selection for seizure-prone men. These are men with CNS disease or history of seizures or recent stroke. The more frail elderly patients are at a higher risk with enzalutamide-induced falls, and so I would consider abiraterone in those men, particularly if they've had a history of falls. But enzalutamide might be safer in men with significant cardiovascular risk factors, given the hypertension, the need for prednisone, the risk of promoting worsening diabetes or metabolic syndrome. If you have contraindications to prednisone, such as the use of immune therapy or really metabolic complications. And so modest differences in efficacy, but really and modest differences in safety. And largely the drug that you pick first will be the one that patients will be on the longest for about a year and a half. And so some practical guidance for the use of enzalutamide, again, it's level 1 evidence. It's 4 40-milligram capsules, and this is likely to change in the next year. to be a little bit more convenient with or without food. I do recommend home blood pressure monitoring. I encourage all men to exercise regardless of the enzalutamide, but even more important on enzalutamide to reduce that fall risk. I don't restrict driving or activity because of the rare risk, but I am particularly careful at not prescribing this drug to patients that are very high risk for seizures, and these are some of the guidance here. Now, for abiraterone, it's a little different. It's 4 or 500 milligram tablets. You take it about an hour before breakfast, ideally, or 2 hours after food because of that bioavailability issue. It is level 1 evidence, regardless of symptoms and prior docetaxel. While it hasn't been studied in men with visceral disease pre-chemotherapy, it does have activity post-chemotherapy in those patients. Because of the blood pressure issue, this is a specific toxicity of mineralocorticoid excess. There are some agents that can reverse this, such as eplerenone, but you can certainly use other blood pressure medicines like diuretics or ACE inhibitors, calcium channel blockers, for example, to combine with this. Again, exercise is important. I do more liver and electrolyte monitoring than I would with enzalutamide because of the specific toxicity of mineralocorticoid excess. And for patients with significant cardiac disease, because of these risks, I would consider a pre-op or pre-treatment cardiac evaluation. Practical aspects in follow-up, this is not in the NCCN guidelines, but just some things that were done in the way that the studies were conducted and the way that I practice. So I check PSA at 6 weeks along with some of the metabolic profiles, particularly the abiraterone, and then every 12 weeks. And I do CTs and bone scans every 12 weeks. We have looked at there are some patients who can progress on scans without obvious PSA progression, so it's important not to ignore the scans and just make decisions on PSA alone. So this is commonly seen in practice where you rely a little bit much on PSA alone. So I do image patients regularly. If they're having a great response, you can certainly discuss with a patient spacing that out a little bit more as they're doing well. But because you can see radiographic progression even in the liver or lymph nodes without much PSA progression, I wouldn't neglect the scans. I do want to emphasize that bone scan progression can be very confusing and misclassified, and I have a slide coming up on this. And I don't stop abiraterone or enzalutamide just for PSA-only progression. You can often see a drifting upwards of PSA, which can precede radiographic or clinical progression by many months, and you can see the PSA sometimes bounce around quite a lot. So I really try to hold off for more disease manifestations other than PSA here. This is an example of bone scan flare, and so bone scans, they can be difficult to interpret because they only indirectly image the tumor. This is a patient who did really well with abiraterone, for example. His PSA was 200, and he had a sternal metastasis. His PSA went down to 2, and he had a bone scan flare, this new rib lesion. And he was able to stay on the study because of this new working group guideline, which accounted for this flare, and so he got a confirmatory scan which did not show additional new lesions, and he was able to stay on this drug for 2 full years, obtaining the clinical benefit. And I think if it wasn't for this working group too, we would probably have not had the success of getting these drugs to patients as quickly as we did, because flare is actually common. It's almost half of patients treated with Abi and Enza. So if you don't understand that this is a healing reaction, that this is just bringing out an occult metastasis through an osteoblastic reaction around the tumor, and that this is not clinically important, patients are doing well, this occurs in the setting of response. So if you have a patient who's responding, their PSA is going down, they look and feel well, you should really treat the patient, not just the image or the PSA. And this tends to really occur just in the first 3 months. One of the most disconcerting things that we've seen since the approval of Abi and Enza is the cross-resistance. So Enza after Abi and vice versa, really you see cross-resistance in many patients, actually the majority of patients. Only about a third of men will respond to crossover oral therapy. Often these crossover agents, they don't work for very long, a very short time to progression of 3 to 5 months. And you see this regardless of the order in which you use them. There's about 7 papers out now, more just chart reviews or large series, with the inability to really predict who's going to respond to one drug. For example, these group of patients progressed on both drugs, while this group of patients responded on this PSA waterfall plot to both drugs. And you can see patients who respond to one but not the other, or the other not the one. So we're really seeking biomarkers that will help predict when one drug will work. And some of the putative biomarkers are these androgen receptor splice variants, where this whole ligand binding domain is lost, and there's some new cryptic exons inserted, but these AR variants can bind to the DNA, turn on that AR program. They don't need to necessarily dimerize with each other, but they can dimerize with wild-type AR, and they can turn on the AR program, and they're not blocked by any currently approved drugs. There are many other pathways, other oncogenes, neuroendocrine changes, other pathways that are operative here, which we're seeking out drugs to block. Just some examples where you measure the AR variants through a circulating tumor assay, and this is the Hopkins data, where essentially if you were ARV7 positive, you didn't benefit from either enzalutamide or abiraterone. PSAs went up, versus ARV7 negative patients had a clear clinical benefit and their PSAs went down. And we're validating this now in a multi-center trial. So there's 2 questions here. Let me get to those in just a second. This is, again, just really looking at a future biomarker. ARV7 is clearly associated with this cross-resistance, and enzalutamide patients who have this have a very short-term benefit or none at all. Same with abiraterone, hazard ratio in the 6 to 16 range. And so there's actually a CLIA-approved test now. It's not currently NCCN recommended, mostly because it has not been externally validated yet, and those studies are ongoing. So we actually hope that we will have future guidance around this once that we have an FDA-approved test with external validation, that we can use this test to help inform on which drugs not to use, such as Abi or Enza, and which drugs to use, such as taxanes, where these drugs may work better in these V7-driven patients. Case number 2, we're going to move on to some other therapies now. So this is a 69-year-old man. He had a Gleason 9 low PSA tumor. He had surgery which showed a high-risk cancer, tertiary 5 pattern, T3 extracapsular disease at surgery, and he got adjuvant radiation, but unfortunately his PSA went from 0.1 to 9 to 44, and he was restaged and found to have multiple bony mets, bulky retroperitoneal nodes, and he was treated with ADT and docetaxel. So this whole hour is spent on CRPC. We're not going to get into CSPC, but that is one of the important changes to the NCCN guidelines, is the recommendation, particularly for men with high volume disease, is to use induction docetaxel 6 cycles without prednisone with ADT. And you can see this man's bulky retroperitoneal nodes, his widespread bony disease. This patient would have a large survival benefit as long as he's chemo fit for early use of docetaxel. And after he gets through with induction docetaxel, he's on ADT, his adenopathy is resolved, his bone mets are still there, his PSA is down from a very high number to 2, but within 12 months his PSA goes up and he develops diffuse migratory bone pain. You see new bone lesions. The patient is treated with Enza but doesn't progress. He progresses quickly within about 6 months. And so where does this fit into the NCCN guidelines? This would be a patient without visceral metastases. It's in that subsequent page, so this is PROS 12. You flip the page, you look at prior therapies, and based on prior docetaxel, we have different level 1 evidence for enzalutamide, Abi, radium, and cabazitaxel. Or Sapulus LT is appropriate, again, if you meet the eligibility and you haven't had it before. But again, you have to have a good life expectancy. You have to be asymptomatic. This patient clearly has already had Enza. They've already had docetaxel. We're going to focus more on radium and cabazitaxel at this point. So I'm going to give this back to Bridget.
Right, thank you. So radium-223 is a beta-emitting radioisotope. And this is unique compared to other bone-tropic radioisotopes that you may remember from the past, strontium and samarium, which were beta emitters. And the main difference here is a physical one, in that the alpha emitters, the alpha particle is a helium nucleus. It's a large particle, whereas the beta is much smaller, and so the range is quite different for the two. All of these are bone-tropic, so they go to areas where there is bone turnover. So a blastic lesion of prostate cancer, the radionuclide will tend to focus on those areas. And then the alpha particle has a very short range of about 2 to 10 cell diameters, so it's primarily targeting tumor, whereas the beta particle targets both the tumor and more of the bone marrow.
Sorry.
You're good. So radium has the same chemical properties as calcium. So and you see here calcium, then strontium, barium, and radium. So these all are bone-tropic, and they're concentrated in the blastic bone lesions. And that's really why you get the tumor-centric effect. Go ahead and pass the next. This is a schema of the ALSYMPCA trial, which was a phase 3 trial evaluating radium-223 dichloride compared to placebo in men who had confirmed symptomatic castrate-resistant prostate cancer. Those patients had to have either completed docetaxel or were considered unfit or refused docetaxel, and that was a stratification up front. Important to note that these patients had bone-only disease. They did not have any known visceral metastases, and they were symptomatic. And those are two key features in terms of how radium has been approved. The best standard of care included local external beam as necessary for pain, steroids, antiandrogens, estrogen and ketoconazole as considered appropriate by the treating physician, and the randomization was 2-to-1 for radium to placebo. The primary endpoint was overall survival. The radium arm had a median overall survival of 14.9 months compared to 11.3, so a 4-month improvement and a 30% reduction in the risk of death overall. And then when subgroups were analyzed, the radium was generally beneficial in all subgroups, although a few did not meet significance, primarily because of small numbers. Of note, I think that the point here that I wanted to make is that patients were stratified by alkaline phosphatase level and the number of metastases, and in both cases, there seemed to be a greater benefit in patients who had a larger volume of disease. So patients who had an elevated alkaline phosphatase had a greater effect than those who had a normal alkaline phosphatase. And then this is the toxicities that were noted in the trial. So overall, radium-223 was very well tolerated. It does have some hematologic effects, but generally the toxicity is quite low. If you note, the grade 3 or 4 thrombocytopenia was 6%, which was increased to placebo, 12% for all grade 3 thrombocytopenia. The neutropenia risks were also different, statistically different, but very low overall. The only non-hematologic, the only non-hematologic endpoint that was different was the diarrhea, which was 25% compared to 15% for all grade, but the high grade diarrhea was very low and not statistically different. This is analysis by previous exposure to docetaxel, and so you're looking at on the left previous docetaxel use, and then on the right those who did not receive docetaxel and were not planning on receiving it in the future. These were people who had denied or were unfit for docetaxel. And if you note that the hazard ratio is about the same in both, so again a 30% reduction in risk of death in both groups. And again, the toxicity is very low in both, although the folks who did not receive docetaxel did have a lower hematologic risk. It is important to note that this data for ALSYMPCA is only in people who did not go on to receive docetaxel after radium, and that is an ongoing concern about toxicity, and it is being studied in current trials. So this is actually a duplicate, so we can thank you. So to summarize how we use radium-223, It is administered once every 4 weeks for 6 cycles over a 6-month period of time. It's a very quick IV infusion. It can be given by either radiation oncology or nuclear medicine, and that's really driven by individual practice patterns. It is excreted enterically, and there's no pre- or post-medication that's required. As a safety check, it's reasonable to do a CBC prior to each treatment just to ensure that your patient is not one that's having a thrombocytopenic reaction. The clinical benefit, the primary endpoint is in survival and also in symptomatic skeletal-related events. We think it may have a greater effect in patients with higher volume of disease in terms of number of metastases or high alkaline phosphatase, and it should be considered in symptomatic men who have bone-only castrate-resistant prostate cancer. There is some thought about the role of spinal imaging in terms of epidural disease and if that disease could swell and cause a spine injury. And so if you have patients who have a significant amount of epidural disease, you may want to do spine imaging to rule that out prior to initiating a treatment. And palliative external beam can be used to treat the epidural disease, as the radium-223 primarily treats bone, within cortical bone metastases. And then, as I commented earlier, there's no head-to-head data for comparing to a docetaxel yet, although those studies are being done currently. So to review the NCCN guideline in this setting, radium-223 is recommended for symptomatic bone-predominant metastatic castrate-resistant prostate cancer. Can be used either after docetaxel or in patients who docetaxel is not going to be given, and then to follow the patients for bone marrow toxicity. And in addition, continue the other use of hormonal therapies and other supportive care as appropriate. So this is, I think, our last slide, just as a visual summary of the NCCN evidence-based recommendations for M1 CRPC. These boxes are a visual representation of the 5 components of value that NCCN has developed to help with a visual way of how to rank the evidence. And so you see here, in terms of, it really separates it by visceral and no visceral metastases, but the role of abiraterone and enzalutamide are very similar. The 5 components are run along the x-axis, and they're safety, quality, and quantity of evidence, consistency of evidence, and affordability. And so in terms of the higher up you go on the blue bar, the stronger the evidence is. So thank you for your attention.